Thank you very much for the kind invitation to speak about the therapeutic advances in hepatitis B virus infection. This slide shows you my conflict of interest disclosure. And first of all, we have to remember that the number of deaths related to viral hepatitis is worldwide approximately 1.5 million, half being due to chronic HCV infection, the other half being due to chronic hepatitis B virus infection, which itself splits into two halves, half of them related to the complications of cirrhosis, and the other half about the complications of hepatocellular carcinoma. Let's first briefly review the current hepatitis B virus treatment. This slide is taken from the EASL clinical practice guidelines on hepatitis B treatment, and you can see here that there are currently two types of treatments that are approved and broadly used. The first one is the use of pegylated interferon alpha, which is indicated for 48 weeks. It is an initial treatment option for specific groups of patients with mild to moderate HBAG positive or HBAG negative chronic hepatitis B. And essentially, this treatment is for patients who are infected with genotypes A or B, who have a low HBV DNA level and elevated ALT levels. The second most broadly used treatment is lifelong nucleoside analog therapy. This is a treatment of choice for the vast majority of patients, regardless of the severity of liver disease, and the preferred regimens are monotherapies that can be based on the use of entecavir or of tenofovir, which exists under two different forms, tenofovir disoproxyl fumarate and tenofovir alafenamide. This slide shows you the biological results over 5 years of tenofovir therapy in both HBAG positive and negative patients. And as you can see, the HBV DNA becomes undetectable in the vast majority of patients, whatever they are HBAG positive, 97%, or HBAG negative, 99%. In HBAG positive patients, approximately half of them will lose HBe antigen, whereas seroconversion will happen in 40% of cases, and only 10% of HBAG positive patients will experience an HBs antigen loss, with HBs seroconversion occurring in 8% of cases. In contrast, in HBAG negative patients, HBs AG loss is very rare, less than 0.1%, and no patients did seroconvert in the HBS system. Slide shows you now the results in terms of histology of 5 years of treatment with tenofovir, with a very significant improvement in both the nodal necroinflammatory score and the Ishak fibrosis score. So this is a good treatment virologically, as most patients are controlled, and also good treatment in terms of clinical outcome with reduction of inflammation and fibrosis. How can we currently optimize the current HBV treatment? There are two options for optimization of current HBV treatment. The first one is the combination of a nuke with pegylated interferon alpha. And the second, which is very much in vogue these days, is stopping nuke therapy, and this is a new strategy. For the combination of nuke plus pegylated interferon alpha, there are three potential options: simultaneous combination, the two drugs are given at the same time; sequential or switch combination, with the nuke being given for a finite treatment duration and then switch to peg interferon alpha; and the add-on combination, which consists in starting with nuke, continuing the nuke lifelong, and having a course of peg interferon alpha in the middle of these treatment strategies. The results have been somewhat disappointing. You can see here the results of a study published in Gastroenterology in 2016. You can see here that the patients with HBs AG loss were 0% on tenofovir only. With pegylated interferon alpha administered alone for 48 weeks, the rate of loss of HBs AG at 72 weeks was 2.8%. And it was not different in patients who had peg interferon and tenofovir combined for 16 weeks, and then tenofovir continues, 2.8 as well. And the group with tenofovir plus peg interferon for 24 weeks, slightly longer duration, did a little bit better, 9.1%, but the difference was not significant. This other study shows you the results of sequential add-on nuc plus peg interferon therapy with virtually no difference in terms of mean reduction in quantitative HbA1c levels between patients receiving entecavir monotherapy, this is the dashed black line, patients receiving entecavir add-on, this is the dark gray line, and patients pretreated with entecavir, all of them receiving peg interferon alpha as a sequential add-on therapy. So the conclusion of that is what EASL has recommended, which is in fact a recommendation of not using, and what EASL said in its recommendations in 2017 is the following: de novo combination of nukes and peg interferon alpha is not recommended. In treatment-naive HbA1c positive patients, short-term pretreatment with a nuke before peg interferon alpha is not recommended. And finally, in long-term nuke-suppressed chronic hepatitis B patients, adding peg interferon alpha or switching to peg interferon alpha is not recommended either, and this is where we are at the current point. The second option for optimization of current treatment is stopping nukes, stopping nucleoside analogues after HbA1c or HbA1c loss. And what EASL recommends is that nukes should be discontinued after confirmed HbA1c loss with or without anti-HbA conversion. The nukes can be discontinued in non-cirrhotic HbA1c positive chronic hepatitis B patients who achieve stable HbA1c seroconversion and undetectable HBV DNA and who complete at least 12 months of consolidation therapy. But finally, in all cases, close post-nuke monitoring is warranted. The point of discussion remains about stopping or not stopping nukes in patients who are HBe antigen negative, and this is heavily discussed, and the conclusions so far are not very clear. You can see here the results of a German study in which patients were randomized into stopping tenofovir, long-term tenofovir, or continuing tenofovir. And you can see at the bottom here of this slide that the patients who continued tenofovir had no HbA1c losses, and the level of HbA1c remained very stable over time, whereas different courses happened in patients who stopped tenofovir. The HbA1c kinetics are shown here in the patients who stopped tenofovir. A few patients lost their HbA1c. They are shown in the black lines here. A few other patients had decreases of their HbA1c levels over time. And finally, other patients had no changes in HbA1c levels over time. And within this group of patients who had no changes, some of them had increases in ALT levels and had to restart therapy. So different courses, but for sure, stopping treatment does something and is different from continuing in terms of HbA1c loss. And this led to the current recommendation in the EASL guidelines saying that discontinuation of nukes in selected non-cirrhotic HbA1c negative patients who have achieved long-term, more than 3 years biological suppression under nukes may be considered if close post-nuke monitoring can be guaranteed. What about new HBV therapies now? The HBV therapeutic field is in continuous development. There are many drugs in preclinical and clinical development, and we'll try to review the current state of the art. This is the cellular cycle of the hepatitis B virus in hepatocytes. After attachment and penetration, the virus is uncoated and transported to the cell nucleus, where DNA repair will lead to the synthesis of cccDNA that will persist in the cell, and cccDNA will serve as a matrix for the formation of pregenomic RNAs and different HBV RNA transcripts that lead to the formation of the different viral proteins, core protein in particular, which is used together with the pregenomic RNAs to be encapsulated. The encapsulation leads to DNA synthesis in the nucleocapsid. Then the nucleocapsids are enveloped. The formation of the circular DNA genome is finalized, and the viral particles are released at the surface of the hepatocyte. All of these different steps of the viral life cycle can be targets for different modes of intervention, different inhibitors. There are drugs that block entry of the virus into cells. There are drugs that target cccDNA, either destructing it or inactivating it. There are drugs that target directly HBV RNA and the expression of our proteins. There are drugs that target capsid and packaging, drugs that target DNA synthesis, for instance, the nucleoside, nucleotide analogues, drugs that target assembly and export, and obviously also compounds that may stimulate the innate or adaptive immune response. This slide shows you a non-exhaustive list of HBV drugs in the pipeline, and this concerns only direct-acting antiviral drugs, which split into two main groups. The first one is a group of capsid assembly modulators with many drugs in development, and I will show you a few examples. And the second one is a group of nucleic acids. This includes silencing RNAs, antisense oligonucleotides, and nucleic acid polymers. All of these are nucleic acids. The second group of drugs that are in the HBV pipeline are immune and host-targeted therapies. This includes several TLR agonists, therapeutic vaccines, drugs that perform gene editing, and many other potential mechanisms of action that are aimed at reducing the viral replication, increasing the reaction of the host, and ultimately leading to a loss in HBs antigen. Let's review some recent results obtained with the capsid assembly modulators, which we call CAMs, for capsid assembly modulators. There are actually two groups of capsid assembly modulators. You can see here the class 1 CAMs, or CAM-A, which form aberrant non-capsid polymers, and the class 2 CAMs, or CAM-N, which form empty capsids devoid of pgRNA and rcDNA. The first example I want to show you is a drug which is currently in phase 2 and will very soon be in phase 3. The drug is called JNJ6379. It's a class 2 CAM. And you can see here the results of a phase 1b non-cirrhotic HbAg positive and HbAg negative chronic hepatitis B study. The drug was administered for 28 days, and as you can see, there was clearly dose-related significant decrease of HBV DNA levels for the entire duration of administration, and then a very slow but sharp re-increase of our replication after the drug was stopped, which clearly shows that these drugs are potent antiviral drugs. However, there was no effect on HB antigen or HBs antigen levels. These are similar results with another CAM called vebicorvir, another class 2 CAM. This is a phase 1b study in patients mostly from Asia, administration for 28 days. And you can see here the effect in HbAg positive patients, which was dose-dependent, and also a very clearly dose-dependent effect in HbAg negative patients. In this study, the drug was safe and well-tolerated, but again, there was no effect on HB antigen or HBs antigen levels. What happens if you combine a CAM, capsid assembly modulator, and a NUC, nucleoside nucleotide analog? This has been done in this study where vebicorvir was given in combination with entecavir. And you can see here on the gray line the effect of entecavir alone, and on the yellow line, the effect of the combination of entecavir with vebicorvir. And clearly, vebicorvir had an additive, at least additive effect on viral replication, which indicates that better antiviral inhibition can be obtained by the two drugs in combination than by one drug alone. And you can see here that when in the entecavir alone group, vebicorvir was added, this group caught up on the other one, and the additive effect was visible as well till the end of the study. After these first generation CAMs, we will see the advent of second generation drugs, and there has been a presentation at EASL where vebicorvir, the currently in phase 2-3 study drug from Assembly Biosciences was compared with second generation drugs. And you can see here that this was done in vitro, and the antiviral activity, you had a much improved antiviral activity with the two second generation drugs, ABI 2158 and ABI 3733, and also a better effect on the prevention of cccDNA formation of these two second generation drugs compared to the first generation vebicorvir. So the development of CAMs raises a few questions. CAMs are direct-acting antiviral that block the HBV life cycle at currently investigated dosages. But the questions are, will they be additive or synergistic with the nukes? Will this translate into more HBsAg losses? What will be the impact of CAM resistance? And can high enough exposures be reached to block cccDNA replenishment in addition to generating empty capsids? And will this provide a better chance to clear HBsAg? All questions that will have to be addressed within the next few weeks to months in the currently underway studies and future studies that are being built. The second group of drugs for which I would like to show you some results are the nucleic acids, and we will start with the silencing RNAs. And the first one is the J&J 3989 drug, which used to be called Arrow HBV. This study clearly shows an effect, this time not on HBV DNA, but on HBsAg levels. And you can see here individual data of HBsAg level reductions on treatment with the silencing RNAs. It's normal because the siRNAs target messenger RNAs and the synthesis of HBs antigen. And you can see here two groups, a group of off-treatment sustained HBsAg responders, 15 patients, and the group of initial responders in gray were not off-treatment responders. And the dashed line shows a group of HBsAg non-responders, which was made of only one patient. All of the other patients responded by a decrease that could be sharp or less pronounced of their HBsAg level. This slide now shows the results of a logical combination, the triple combination of a silencing RNA, J&J 3989, a CAM, J&J 6379, and a nuke in a small number of Asian patients. You can see here the log HBsAg change from day one in blue, and in orange, the absolute HBsAg level. And you can see that this triple combination was quite efficacious in reducing HBsAg levels. But comparison with the other studies performed before in monotherapy indicated that the effect did not appear to be greater than the effect of the siRNA alone. However, long-term duration and particularly off-treatment response remain interesting questions with the triple combination that will be addressed and solved in the next few weeks. Beside the J&J drug, Arbutus has also an siRNA called ABI 729. These are results presented at the last EASL meeting, which show in HBsAg positive and negative patients who are on treatment with nucleoside nucleotide analogues with undetectable HBV DNA and with different schedules of administration of the siRNA, that there was a sharp reduction in virtually all patients of the HBsAg levels. You can see here treatment given for 60 milligram Q4W, here 60 milligram Q8W, and here 90 milligram Q8W, and in all cases, a sharp reduction in HBsAg levels upon administration of this drug. Beside the silencing RNA, there are other nucleic acids. I'm just showing you one example of an antisense oligonucleotide. This is called JSK404. It's a second generation liver-targeting antisense oligonucleotide. And you can see here that similarly to the siRNAs, although less potently, the antisense oligonucleotide was able to reduce the level of HBsAg in patients' bloods. And importantly, these patients were treatment naive. They were not treated with nucleoside nucleotide analogues, and the reduction was dose dependent. So what are the global potential issues with nucleic acid treatments? First of all, their manufacturing is complex and costly, and this may limit their use in the future. There are potential, at least theoretical, safety issues related to the activation of innate immune responses, to off-target effects related to the inadvertent downregulation of genes with incomplete complementarity, the induction of anti-RNA protein complexes, and also they have a very long half-life. So if you have a side effect, it may take time before the drug is removed and the side effect is solved. And it has also been suggested that there could be possible resistance with siRNAs and antisense oligonucleotides. The very last group of drugs I wanted to discuss with you shortly is the immune and host-targeted therapies. I've shown you this slide before, indicating that there are various approaches for immune and host therapies. However, none of these approaches has clearly shown any benefit so far in the treatment of hepatitis B, and there are several reasons for that. So first of all, these drugs have not been convincing in HPV-infected patients thus far. These drugs must be administered in combination with nukes and or with CAMs and or with nucleic acids that suppress HPV replication. Most studies have not been in combination with all these drugs. Another problem and another challenge is that the ideal immune HPV targets are unknown, so it's difficult to know exactly what drug should be used and what target should be used to have an effect on HPV infection. There is a poor specificity of many immune approaches with a real risk of side effects related to off-target effects. And there is also a clear risk of immune stimulation and the induction of ALT flares in patients who have advanced liver disease. And for this reason, the CAMs on the one hand, the nucleic acids on the other hand, are leading the field of HPV drug development, and the other approaches have been less convincing so far, and therefore remain as question marks for a potential use in the future. This brings me to the conclusion of my presentation, and we can say today that current HPV treatment based on nucleoside or nucleotides controls HPV replication and significantly reduces the incidence of HCC and other clinical events in the long term. The functional cure, which means the sustained HPSAG loss, could further reduce the incidence of HCC while allowing for stopping nuke therapy. A large number of HPV targets has been identified, against which numerous inhibitory approaches are at the developmental phase. And finally, more work will be needed to identify compounds that will be safe and effective and reach approval within a reasonable time frame. On this, I would like to thank you very much again for inviting me and for your attention. Thank you very much.